Hello and welcome to my channel. My name is Peter Abraham. I'm a second career registered nurse focused in the areas of advanced illnesses, typically those that would qualify for either palliative care or hospice care. Those are two separate types of services that are often confused. I'm also a certified end-of-life doula through the International Doula Life Movement, an avid writer having published well over 500 healthcare articles, an avid book author having written and published 21 books for hospice nurses, 24 for caregivers, 5 for holistic nurses, 6 for end-of-life doulas, and I'm currently working on a brand new book that will be part of a brand new series looking at how we can do a walk through grief, integrating grief into our lives as a follower of Christ Jesus, so that we could have a type of healing with the understanding that grief does not go away. So if you're new to this channel, welcome. Thank you so much for taking the time to visit. In this channel, we talk about issues related to death and dying and our journey in that direction. After all, we are all going to die. Shouldn't we know what that process looks like? Shouldn't we be aware of such things as anticipatory grief, which is grief we could feel long before the loss, or ambiguous grief, or other things that we go through in life on our journey? If these are topics of interest, please consider hitting the subscribe and bell notification below. I try to publish videos every Monday, Wednesday, and Friday, corresponding to when articles are coming out on compassioncrossing.info. I have articles written and ready to be published into mid-February of 2026. I'm a geeky nerd, plus being autistic. If you like these types of videos, also do like. It helps spread the videos out, and I do thank you. So the topic for today's video is going to be looking at physician's aid, physician's-assisted suicide. And before we go into the topic for today's video, because I understand this is a controversial topic, and I'm going to be presenting it from a very different point of view, because if you're, how to phrase this, a lot of death doulas will present it from one point of view. I'm going to probably be one of the few odd ones out that will present it from a different point of view. Before we go to the topic of today's video, I want to ask you, what are you grateful for? What are you grateful for? When we look at how do you deal with being around people who are terminally ill or chronically ill, getting worse and worse, and we know that we're all going to die. Everyone dies. We're all going to die. How do you deal with it? To me, it's a matter of building resilience. There are 3 pillars for building resilience. We talk about the third. I want to give you a middle finger. Sorry. We talk about the third here. What are you grateful for? So what am I grateful for? I'm grateful for my viewers, whether I know you or not, whether you comment or not. I'm thankful, even if you stop by, not for me, and you walked, at least you stopped by. I'm thankful for those of you who buy and read my books. That I don't have enough words to thank you. I never knew what what direction that would take. I know I'm not famous, for lack of better words. I have less than 200 people who, quote, follow me on my author page, and who will try to buy every book that I write. But I appreciate every one of you. It not only helps our family in terms of day-to-day living in the times that we live, but it also helps me operate Compassion Crossing LLC on a sliding scale basis. And I do a lot of work for free because I don't want to turn anyone away who could use my help or my services. So thank you. And I'm consistently grateful for my wife, who, if you know anybody who has autism, we could be extremely difficult to be around. We don't want to be, we don't try to be, but we could be very hard to be around because we're not normal. And I'm okay with that, but I also understand that that can cause some distress for people around me. I don't do it on purpose when I have my attacks and so on, but I'm grateful for her. So getting into the topic for today's video. I'm not going to go over the history. I'm going to do some of the word history, not the date history. To be honest, when I how to phrase. Some people will say, look, Peter, you're very intelligent because of XYZ. Maybe it's because of how many books I've written in what time period. When it was, when I was going to hack, it was between Jenny and I, who had the highest GPA. Uh, Jenny, it wasn't a competition. It was a competition between me, myself, and I, because I went to nursing school at 50. But I had the highest GPA at Harrisburg Area Community College, Lancaster campus, for my graduating class. And I was told for many years that was like I broke records, and I wasn't intending. It was me competing against me because I literally didn't know how I was going to do. But there are areas that I outright suck, horribly so. I'm not the greatest with historical dates and times, so we're not going to go into that. But when we look at, many of you have heard of Dr. Kevorkian. I've had fellow doctors bring up Dr. Kevorkian. Usually when they're bringing it up is when I actually hate it. When I say hate, I don't mean hate like I want to destroy the person. It's just explosion in my mind type. Where on hospice, I'm going to keep my love, I view them as a loved one, platonic, brotherly love. They're like an uncle to me, a brother, a sister, a father, and so on. That's how I view them. I'm not telling you how to view them. But they're always to me, like they're dear to me. And I want to do what's right for them. And that means keeping them comfortable, not necessarily at all cost in terms of like breaking any laws or, breaking more morality or ethical frameworks. But I don't have like, oh, here's a drug limit, like a dosage limit, and so on and so forth. If the maximum dose per a drug guideline is XYZ, and they're not comfortable and they're on a minimal dose, I'm going to be pushing higher and higher, faster and faster to get them as comfortable as soon as humanly possible. That's me. Again, if you're watching this and you feel differently, I'm not trying to change your mind. I'm just trying to share information. And at the end of the day, these are, just so that you're aware of disclaimers, this is not medical advice. It's not financial, legal, blah, 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 blah. I'm just sharing my experiences, my wisdom, what I've learned so that my viewers are more informed. What you do with that additional information is your business. Okay. So I still remember, if I contrast, um, and I'm hesitating here, but I don't know of any other way to do it. Okay, uh, I was going to give names out, but I don't want to have. I'm a privacy, not as bad as my wife, but I'm still out there for trying to protect privacy to huge degrees. But I had one doctor that I've worked with, and he was with me 100% of the way. Do whatever it takes. You need to give 20 milligrams of morphine, which is a full syringe, every 10 to 15 minutes. Go ahead. Now, I described the circumstances, wasn't willy-nilly. But I had another doctor who was like, give 5 milligrams more and call me back in a half hour if it's not working. And if I would push for 10 milligrams or 20, I'm not Dr. Kevorkian. So I'm just putting that out there because we're going to be talking. Dr. Kevorkian is known as one of the founders of physicians-assisted suicide. One of the founders of physicians-assisted suicide. Peter, it's not called that anymore. I've asked in other videos, if anyone's watching this channel for any length of time, you know that I like to prod, poke, get you to think critically, especially my fellow nurses. We are actually paid to think. We are paid to engage our brains. So therefore, we should be asking. Part of thinking is asking questions. The scientific method involves asking questions. What frustrated me the most during COVID is most of us who were trying to ask very valid questions like, does the virus know to stop at the plastic face shield and not go around the opening because it wasn't an airtight seal, wasn't go above? And how many nurses had the shield like this, like a visor pulled up? I did that because I found out adult onset asthma. One of the, I don't know if you can see it back here, but on my, one of my picture frames, there's actually a medical prescription that I cannot wear a face shield at the same time of a face mask due to the air volume. I can't get in the air volume. It's really humidity and temperature based. If it's very like if it's I'm outside, it's not that you wear a mask. Well, some people do, blow my mind. But anyway, that's its own rabbit trail. So, but like I would ask those questions. Are you one of those nurses? One of those what type of nurses? The one who questions authority? No, the one who questions science. Nursing science? Hello? Bachelor of Nursing Science? Hello? We're supposed to ask questions. So when I say physicians assisted suicide, we may have changed the words, but what's the reality of the situation? And that's part of what I want to go over here with you. And I do have, because a lot of people, what's the peer-reviewed science? Where's the articles about it? Show me the proof of what you're talking about. So I have some here, or at least one, I should say. So it was originally called physicians assisted suicide. That is what it is. A person is making a decision to end their life. Now, under any other situation, a person who chooses to end their life, it's called suicide. If they take a gun and they blow out their brains, and I'm being vivid, they committed suicide. We use the word death by suicide. We're trying to be politically correct, but they death by suicide. So physicians assisted suicide. So what ended up happening in terms of the history of this movement, again, not giving you dates and times. I'm horrible with that. Physician-assisted suicide. Although those words are too harsh because it brings up suicide. So let's soften it. It was then they're starting to use the word death with dignity. Now, as a hospice nurse, that made me very angry because it's like the majority, like every one of my patients, all of them that, I shouldn't say all, I had one, sorry, I had one. I did have one patient that committed, death by suicide, overdosed, took a bottle of liquid oxycodone, all his morphine, all his lorazepam, and who knows what else, and there might have been other medications and alcohol involved. I did not receive any autopsy results. But out of all my years of being a hospice nurse, one person took their life. I'm be putting in the description below an article, Can You Have Faith and Be a Nurse and live your faith as a nurse? I had a patient ask me to kill them. I did not. And the ending story was actually fantastic for both them, their family, and me. It was proof the patience in God, Christ Jesus, to be very specific. Jesus said, I am the way, the truth, and the life. No one comes to the Father except through me, John 14:6. So it had a happy ending. He actually got to see I think it was a Super Bowl or some type of game he wanted to see. I don't, terrible at sports. He actually got to see that because I didn't kill him. I'll put that in the link below. But it was like, what do you mean? All my patients who did not have physicians assisted suicide somehow had an undignified death? Is that the only way to die with dignity, is if you kill yourself with help? Here's a couple drugs. And then it went into the nomenclature, and I can't give you the date and year, to medical aid in dying. Medical aid in dying. And part of what I want to talk about from a different point of view, because a lot of end-of-life professionals this should be legal worldwide. A lot of end-of-life doulas, this should be legal worldwide. I don't believe that. Now, if that turns you off, I do ask you to please watch until the end, because I do want to go over what a lot of people don't know, and yet there is information out there. I'm pointing to the screen as it relates to this article. There is actually information out there. If there wasn't a sedative drug given to see what actually happens to the person that takes these it's a cocktail. It's a mixture of drugs. If they were not sedated and we actually saw how they were dying, we would see what happened with Jim Jones. If you look at what happened with Jim Jones in Guyana, they made a cocktail too. His wife was a nurse. They made a cocktail. The catch with their cocktail, they used, I believe it was Valium. They were intended to sedate the person enough that when the other component of the medication took hold, that there would be no suffering. If you watch, there are videos out there. If you watch what those people went through, and if we could actually see what the person who's being involved in medical aid and dying was going through, if they weren't sedated enough, maybe you would think differently on things. But what ends up happening, and when we talk about these lethal injections, there's two things going on. There's a sedative element where they basically can't act. They're sedated. And then there's either a paralytic to paralyze the person's lungs so they suffocate to death, or there's a medication to induce a heart attack. I believe people need to know this. Why do you think people think, oh, medically induced abortion's okay, it's safe, except for the baby who's, according to medical science, was alive at the time that they were killed? If we actually saw the process of what was happening, there are ultrasound videos of the doctor going in to inject the lethal injection into the unborn baby, and the baby's trying to get away from the needle. If we actually saw what was going on and saw the ripped apart body parts, will we be pushing this so much? If we actually saw what was going on inside the body of the person who's having physician's assisted suicide, let's call it what it is, would we be pushing for this? Now, I know the counter for this, I do want to keep this video short. I know the counter for this is, Peter, we treat our dogs, our cats, our pets better than human beings. Here's part of the issue. And I know Dr. Andy Arari, myself, and many other, I'm not a doctor, I'm a nurse, but there are doctors out there, there are nurses and other practitioners out there who believe, like I do, that if you get the person to receive palliative care, I mentioned palliative care earlier in the video, palliative care is symptom burden relief. If it's authentic palliative care, now I try to be transparent as much as I can. Not everywhere has authentic palliative care. Authentic palliative care has only one requirement: symptom burden. Just one: symptom burden. The goal of palliative care is to relieve the symptoms as much as possible. If it's authentic palliative care, the level of suffering usually is around the time what you'd go through if you had the flu. Most people can tolerate the flu or having a cold. I'm not saying you want it. I'm not saying throw it on. I want to live like this all my life. But most people, if they had the flu for 2 weeks or a month, I'm not saying they'd probably be miserable, but they wouldn't be, give me a shotgun, I'm going to blow out my brains. I'm being real with you. Um, I went through an advanced life planning class. This was like a negative 10 out of 10 class for so many different perspectives. We were from everything from the students were teaching themselves, because we weren't learning from the instructor, because the instructor was either spending 5, 10, 15, 30 minutes bashing 5 wishes. I'm pointing to my bookshelf. And like you didn't know that Mother Teresa, who's on the back of their literature since 1996, you didn't have a clue where they stood since 1996, and you just figured out that they believe that one is man or woman. That's what science says. Or that they're for marriage between one man and one woman. What would you expect from Mother Teresa? Seriously. But aside from all of that, it was like, somebody asked, what's the difference between this and a gun? Well, it's a pill, or it's liquid. I'm sorry, at the end of the day, it's the same thing. They chose to take their own life. And I am, and so that you are aware, I'm not against taking away somebody's choice. But Peter, you vote for no for medical aid in dying physician. Of course I vote no, because I am also allowed to operate my choice. My choice is that if somebody receives authentic palliative care, and this is where Dr. Andy and many other healthcare professionals that understand how palliative care works. Palliative care works if it's authentic, it's symptom burden relief. You don't need a diagnosis and you don't need a prognosis. You need to have symptom burden. And again, transparency, not everywhere has authentic palliative care. That's why I strongly propose, push, all of us as a society need to educate everyone around it. We need authentic palliative care in our town, our city, our state, our country. Authentic palliative care, symptom burden relief. Hospice is palliative care in the last 6 months of life. Hospice requires, it's a terminal prognosis, and I know Medicare will say, what's the primary diagnosis? And there's a way to get one. At least I believe that, and I'll be talking more about that in March of 2026 when I speak on the one of 3 keynote speakers at a palliative care conference. But genuine palliative care reduce the symptom burden so that the person can enjoy life better than suffering. There's a way around this. If we instead of pushing for physicians assisted suicide, push for palliative care. That's what we should be doing. That's what we should be doing. That we need authentic palliative care, affordable, accessible palliative care throughout the world. That should be our genuine push, because if people understood what goes in this, and this I'll post the link in the description below. People understood what is involved. The paralytic agents paralyzes the patient's lungs or induces cardiac arrest. These are the same types of drugs that are used for people on death row. And what is amazing to me is the people who push that we need to get to not kill people on death row, push for physicians assisted suicide. Peter, you're not using the words medical aid in dying. No, I'm not. Because I really want you to think, what are we actually doing, and why, and more importantly, what are the alternatives? The alternative is affordable, accessible palliative care that is authentic, that it only deals with symptom burden. I don't care what your diagnosis is. I don't care what your prognosis. Prognosis is how much longer do you have to live. Diagnosis, what condition you have. The reason I bring out, I don't care about what your diagnosis is look at fibromyalgia. A lot of people for many years, I went through, when I say I went through this, I don't have fibromyalgia, but I know the history, not from date and time, but I know the history because I was around when it was thought to be a mental illness. And then I'm still alive when it was like, gee, it's an actual medical condition. It's a diagnosable, it's a medical treatable condition. So I've been through that. That's why I say authentic, don't ask about the diagnosis because it shouldn't matter. What matters is symptom relief. If we're treating the symptoms where the person can now have a higher quality of life, enjoy life. I mean, we're on the landing script. For those of you wondering how much longer is Peter going to talk, we're on the landing script. One of my thank God events, and I have many in my life, it's a gratitude event. I had a colon cancer patient near the Pennsylvania-Maryland border. This is when I was living in PA. And I was working for a Sierra Care Hospice of York, PA. And Dr. Barr, if you ever watch my videos, you're on my, like if I had a doctor I had to pick that wins. I'm not saying you're perfect, Dr. Barr, by the way, but like he's amazing. And so that you are aware, if you're watching this, I'm one of those nurses. I do the S bar. So I went to Dr. Barr, I did all my homework in advance. I got this patient, colon cancer patient. I walk into the house. I had a rural hospice. I had mainly home patients. And I get to the living room where this person is. And he's on his sofa and sitting like in such a weird, he's almost like on the wall. I'm like, not, is this Spider-Man type of thing? And it's such a weird, awkward position. And I am literally like this, trying to see like look at him face to face. And I shouldn't have asked, sometimes you just slip with your questions. All questions are good, but sometimes some questions are better left unasked. Are you comfortable like that? I should have known that the answer was yes. And in a way, I'm glad I'm asked, because he actually had, there were components of the answer I would not have known had I not asked. He said, yes, this is like, I'm a mechanical engineer and I know my body. This is the only position. If I wasn't like this, I would be in so much pain, I couldn't talk with you. He said, and he had his doctors was the lead physician for Cancer Care Associates of York, Dr. Dan. Dr. Dan sort of, I'll kill his last name. Most of us just refer to him as Dr. Dan. If you're from Pennsylvania, especially if you're from York, if he's still practicing 2025, you probably know who I mean. His reputation is wham, above the roof. Wonderful, wonderful. Everyone who's ever had him loves him to pieces in terms of a good way, a good way. He treats his patients as fellow human beings. He takes the time. He cares. He's one of those rare doctors like Dr. Barr that is like authentic, genuine, loving. And he said, Dr. Dan told me he can't do anything more for my pain. He said, I'm at a point where he's recommending hospice. I can't do anything else. So I went through his med list, and fellow hospice nurses, you were watching this. He was on a combination of oxycodone and OxyContin. I do not remember the doses or the frequencies. This is several years back. But what I do remember, and this is why I'm bringing it out to you, my fellow hospice nurses, please, please, please remember that drug conversion rates. OxyContin and oxycodone, there's not a one-to-one ratio from OxyContin to MS-Contin, from oxycodone to short-acting morphine, the tablets, IR. It's not a one-to-one. So I did the math to convert everything to morphine, the appropriate products, the OxyContin, the MS-Contin, the oxycodone, I went with the liquid morphine so that we'd get a PRN, journal going on. And I did the math of what should the increase be based on how he rated his pain. And I presented it to Dr. Barr, who authorized it. I put it out there that way to encourage my fellow hospice nurses. Yes, if you pour into this, I have a book, Hospice Pharmacology. I have a book, Clinical Pathophysiology. I'll put them in the description below. And by the way, the books, if you just read them, it's not going to say, here's what Peter did so that you could do it too. It's to start you on the journey to master the clinical thinking so that you could be calling your doctor and saying, this is exactly what I need, versus, doctor, this is what the patient was taking. It's not working. Tell me what you want to order. And if you are that type of nurse, that's okay. Many are, but you can get to a point where you're comfortable saying to the doctor, this is what I want and why. This is what he was on. I did the math. This is what I've increased and why. And if you're very good at it and you have a good relationship with the doctor is going to say, go for it. Good job. And then you're back the next day and you're having it, like in this case, it was an accelerated visit schedule, which basically means I'm seeing this person more often than normal, routinely, until we made sure everything was managed properly. So this was so successful. And this is why I thank God, I thank Dr. Barr for the yes. And I'm so grateful. He and his wife were able to go on a vacation to Rehoboth Beach with they rescued greyhounds. They took, I believe it was 3 of their greyhounds to this last vacation. Now, yes, he got worse. He got to a point where he needed a subcutaneous pain pump to control his pain. he developed, and I'm not going to keep this too long, he developed a fistula between his rectum and his bladder. So he would be urinating feces and having bowel movements that were urine. It was horrible. It was horrible. Yet we were able to control all of his symptoms. We were able to palliate. Palliate means to make pain less harsh. We're able to keep everything under control, that he died with dignity, without physician's assisted suicide. This is why I get upset with the push for this, because I believe that with proper palliative care, which could be for decades before somebody needs hospice, or hospice, between the two, there's not a need to die faster. That's why I do videos of, we have to watch for serotonin syndrome that can mimic terminal restlessness. We have to look at that when reversible causes versus irreversible causes, because we're not there to make anyone die faster. We're there to remove preventable distress. I had a 104-year-old on the landing strip. I had a 104-year-old who was dying from 3 blood pressure medications and an anticoagulant commonly known as a blood thinner. Regular prescription medications was killing her. Did detective work, got her off with the, again, I can't deprescribe as a nurse, I have to involve the doctor, but got them deprescribed, and she might have made 105. I couldn't do the HIPAA, like I recommended. She got discharged from hospice, but the medication's killing her. So I'm doing this video. This is where we are ending. I'm doing this video so that there does not have to be a push for this. Now, if you want to keep your mind at where you're at, you do you, I do me. I'm glad it's not legal in the state of Kentucky. Every time it comes up to vote in Kentucky, I'm going to be voting against it. And I'm going to be educating others to vote against it. And if they do, they do. And if they don't, they don't. I'm not the master controller, or I forget the Pied Piper, somebody that, hey, follow me and be a cult leader and so on and so forth. I want people to be able to think for themselves, but I also want them to understand, you know what you're doing in the whys. And you don't have to explain the whys to me, that's your own business. But have you gone through the thought process of, like, do you believe that we're going to do this because we treat our pets differently, and I want to be in charge of when I die. And I'm not saying you're wrong. I've had patients feel that way, but I do also want you to know that there are alternatives that are just as dignified, if not even more so. To me, more so is the gentleman, and again, I'll put in the description below, who asked me to kill him. And this is the last paragraph. He asked me to kill him. And this is one of the few times I broke down with a patient. I am crying. We're literally, we sat on, I'd meet him we'd sit on his sofa. That's where we'd have our meetings at his house. Again, rural hospice. And I am bawling. I can't. No one would know. His wife's out on errands. No one would know. They're all in the fridge. No one would know. And I'm like, my God, Jesus would know. God is omniscient. He knows everything. He would know. I would know. And if it ever got out, I would lose my nursing license. I know some people might view me as a hero, but I would be a villain to many. I would lose my entire career, my reputation. I could spend time in jail. I'd ruin my entire family. No, I'm not going down that road. So this individual, esophageal cancer, lost his airway. And that's where our team did palliative sedation, which is legal in all 50 states. And so palliative sedation was done. Miraculously, the miracles still happen in our day and age. He regained his airway, and I'm seeing him every day. And I saw him on a Saturday. It was a beyond. For those of you, my fellow hospice nurses, you know what this is like. You're doing you not only did the week. It was my on call. We're talking. This is like a 60. I'm sorry, 70, 80-hour week on call. My day started out in, I think, Fairfield, Pennsylvania, which was out west. This individual lived. I don't want to say where they live, but they're in PA. But it was a long day, and I started my day. I think I left the house at 6:30 a.m. and I'm getting to his place. I think it was like 7 p.m. at night, and he was my last visit. And he's upstairs in the bedroom. Lots of family there, and it's some type of ball game, football, baseball. I literally don't know. And he's up in bed, in a normal bed. You don't have to have a hospital bed. That's one of the myths about hospice. They take over, they do this and that. No, we recommend. But he's in bed. He's in and out of consciousness. And so I did my entire visit, made sure all the meds were accounted for, made sure they didn't need any refills, talked to the wife, any needs, all emotional, psychosocial, etc. I went up to say goodbye, and he was awake, and he's watching the game, in and out of consciousness, drifting off. And I bend over and I said, "You can go now. You can go now." And he looks up at me, and he, in a very hoarse voice, but I understood him, "I want to watch the end of the game." Or it may have been, "I want to know how it ends." And the moment it came out of his mouth, because he knew what he asked me, it was literally days before that he asked me to kill him. We're talking less than 7 days have passed. He realized what he just said. And then he's looking at me, and he burst out laughing. He burst out laughing. I start laughing with him. And I said, "It's on you. It's on you." And I meant that in love and humor. And I went home and I had to finish my charting. It was a very long day. And my day didn't end until 8 a.m. Monday morning. I'm sorry, this was a Sunday. I apologize. This was a Sunday when this happened. It wasn't a Saturday. I apologize. It was a Sunday. 8 a.m. Monday morning. I got a call. It was between 1 and 3 a.m. Monday. He passed. I went over and I pronounced him. He got to see the end of the game. Had I killed him, had there been a type of assisted suicide, he wouldn't have saw the end of the game. He had a higher quality of life for whatever life remains. And that's the end of this video. Thank you and goodbye.